Good afternoon and welcome, colleagues and friends, to the 2021 Massey Grand Rounds Symposium. My name is Dr. Abby Angel, and I've been part of the MGR program since its start. I'm pleased to provide some background perspective of the Massey Grand Rounds program and this year's symposium. But first, it is customary for Principal Nathalie DeRosier to give the Land Acknowledgement Declaration and welcoming remarks. Please, Principal DeRosier.
Welcome to Massey College. Bienvenue au Collège Massey. Massey College is built on Indigenous land, the land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. We want to acknowledge our duty of stewardship toward the land and the great privilege that we have to meet here all together to discuss the impact of COVID, mind and heart. So I can't wait to hear about this as we continue to reflect on the impact of COVID for all of us. So thank you, Dr. Angel, for inviting me, and thank you to the organizing committee for doing this fabulous presentation. I'm very much looking forward to hearing you. Dr. Angel.
Thank you. Massey Grand Rounds, now in its 15th year, was founded to nourish members of the Massey College community by hosting talks and convening social gatherings with leaders in medicine and health sciences. It provides a discussion forum for topics related to medicine, health sciences, and issues of interest to our graduate students. Every year in March, MGR Junior Fellows organize a major symposium to engage a wider community and develop a program to discuss critical health issues of the day. Today's topics have attracted online registrations from across Canada, with registrants from Hamilton, London, Kingston, Ottawa, Montreal, Winnipeg, and Vancouver. We're delighted with this reach. Precisely a year ago, our MGR symposium was canceled because of the COVID-19 pandemic lockdown. As fallback, we planned an in-person gathering featuring Dr. Sonia Anand, our 2020 General lecturer, but the relentless virus would not comply. Instead, a Zoom MGR symposium took place last September, and Dr. Anand spoke about gender and ethnic variations in health risks. Complimentary speakers at that event included Drs. Julian Hawker and Sheldon Tobe. Special thanks to Dr. Anand for her generosity of time and for agreeing to participate once again in today's symposium, thereby fulfilling her obligations as the 2020 General lecturer. We still owe you an in-person celebratory event, Dr. Anand, so you got something to claim. Each year I make a point of paying tribute to our founding junior fellows. Fiona Menzies and colleagues listed on the right of the panel are shown. This photo enshrines our inaugural MGR lunch in the private dining room at Massey. We have been barred from this venue for the past 13 months thanks to COVID-19, but our resilience prevailed, and thanks to our MGR co-chairs, Krish Bilamoria and Anastasia Karolj, we have had 5 Zoom virtual after-dinner MGR gatherings with guest mentors from the following list. I would like to acknowledge the many academic leaders and scientists who have participated over the years at gatherings with the junior fellows. We have designated the group as our College of Mentors. Those in blue font attended Zoom meetings during this past academic year. Over 85% of those listed here are senior fellows at Massey College and demonstrate a successful integration of senior and junior fellows in their interactions at Massey. We view this as a very productive intergenerational collaboration. A recent feature of the MGR Symposium is the addition of the Janet Rossant Lectureship established by Massey College and the Friends of CIHR. Dr. Rossant's distinguished career as a scientist, builder, leader in medical research, and her dedicated mentorship of young scientists are recognized. The lectureship is designed to host promising mid-career scientists to enliven the intellectual discourse at college. Now, in today's program, we feature Dr. Sonia Anand, the 2020 Resent Lecturer, who will give the keynote talk today. She will speak on the cardiovascular effects of COVID-19 infection, and we note parenthetically, her scientific interests in cardiovascular diseases guided the structure of our program today. Dr. Anand will be introduced more fully by the MGR co-chairs. The program today also features two complimentary talks by two senior fellows, Dr. Allan Kaplan and Dr. Reinhart Reithmeier, who will discuss the impacts of the COVID-19 pandemic on mental health and graduate education, respectively. It is our good fortune to have these accomplished scholars in our midst to help us understand aspects of the health impact of COVID-19 so we can better deal with the challenges on a day-to-day basis. While the spectacular advances in the science of vaccinology are a stunning example of human ingenuity and enterprise, the COVID-19 virus is not yet tamed, and there is a growing fear of a third wave. Today's MGR Symposium addresses important consequences of the COVID-19 infection on the heart and blood vessels, mental health, and its impact on education in both young and old. We look forward to the talks today. I'm delighted with the presentations to anticipate. Finally, MGR and Massey College are grateful to our sponsors who have supported the program since its inception. Thank you to University of Toronto, Temerty Faculty of Medicine, the Department of Medicine, Friends of CIHR, and the Diabetes Research and Treatment Center. I would now like to invite MGR Junior Fellows co-chairs to moderate the talks. Krish Bilamoria is a third-year medical student at U of T, and Anastasia Karolj is a fifth-year PhD student in chemical engineering at U of T who's studying kidney cell growth on artificial scaffolding. Thank you.
Thank you, Dr. Angel and Principal DeRosier, for your wonderful introduction of today's program. Thank you as well to our audience across the Massey community and across Canada for joining us today. Today's program will be on the impacts of the COVID-19 pandemic, heart and mind. Anastasia Karol and I are your two Massey Grand Rounds co-chairs for 2020 to 2021, and we have the pleasure of introducing our three speakers this evening, followed by an open forum where the audience can ask questions about the research programs of our speakers. We will first be joined by Dr. Sonia Anand, Professor of Medicine and Epidemiology at McMaster University, who will be speaking on the cardiovascular effects of COVID-19 infection. Following Dr. Anand, we will be joined by Dr. Alan Kaplan, Vice Dean Graduate in Academic Affairs and Professor of Psychiatry at the Temerty Faculty of Medicine at the University of Toronto, who will be speaking on the topic of psychological protective equipment. Following Dr. Kaplan, Dr. Reithmeier, Interim Vice Dean, Research and Innovation at the Temerty Faculty of Medicine at the University of Toronto, will be speaking about 5 ways the pandemic has changed graduate education. After these three speakers, we'll be joined by Dr. Angel, mentor and advisor to Massey Grand Rounds, who will moderate our open discussion, which can entertain any questions you might have throughout the speaking talks in the last 3 talks. We'll conclude our program with comments from Dr. Janet Rissant and the rest of our organizing team for the event. We hope that our program offers an exciting opportunity for our audience to engage in meaningful conversations on COVID-19, heart and mind.
Thank you so much, Krish. So my name is Anastasia, the other MGR co-chair, and it is my pleasure to introduce Dr. Sonia Anand. She is a professor of medicine and epidemiology at McMaster University, as well as senior scientist at the Population Health Research Institute, vascular medicine specialist at Hamilton Health Sciences and McMaster University, Canada Research Chair in Ethnic Diversity and Cardiovascular Disease, and the Heart and Stroke Foundation of Ontario, Michael de Groot Chair in Population Health Research. She also recently served last year as our 2020 Janet Rissant Lecturer at Massey College. Dr. Anand received her Doctor of Medicine from McMaster in 1992 and had internal medicine training at McMaster, as well as a fellowship at the Royal College of Physicians and Surgeons of Canada in 1996. She earned her master's degree in clinical epidemiology at McMaster in 1996 and her PhD in health research methodology at McMaster in 2002. She received the CIHR Clinician Scientist Awards and is a co-PI of the Canadian Alliance of Health Hearts and Minds cohort study founded by the Canadian Partnership Against Cancer and Heart and Stroke Foundation of Canada. Her research is on the environmental and genetic determinants of vascular disease in populations of varying ancestral origin, and is currently leading 2 birth cohort studies, one among South Asian women of the Greater Toronto Area and the second among Indigenous women from the Six Nations Reserve. So her work is widely published in academic and peer-reviewed journals, and she teaches clinical epidemiology courses in methodology and cardiovascular disease at McMaster. So today we'll have a pleasure to hear her talk, The Cardiovascular Effects of COVID-19 Infection, where she'll overview the effects of the infection on cardiac and brain impacts that continue long-term and how different ancestral groups may be differentially impacted by the infection. Thank you so much, Dr. Anand, and welcome.
Thank you very much. It's a pleasure to be here again. Unfortunately, again, virtually. We couldn't have predicted the pandemic nor how long it would last, but it's a pleasure to be back and certainly a pleasure to present to you some of my thinking and other researchers' learnings of the cardiovascular complications of COVID-19. And I'll just begin by presenting an overview of some of the themes I will touch on in this brief 15-minute session. You can see the picture highlights that the COVID-19 virus does not just stay in one place in the body, it goes throughout the body. And because of that, we have multi-system effects of COVID-19, both acutely and long-term. And this has led us not only to learn how to manage the acute care of patients, but also to now start to think about and observe the long-term implications of patients who have suffered acute COVID-19 in terms of their long-term sequelae. I will also touch on the disproportionate amount of people who come from ethno-racial populations who have a higher infection rate and worse outcomes when affected by COVID-19. And then all of this makes us wonder how our health system may have to change, adapt, and how it will cope with the large number of patients who now need long-term care for COVID-19. So although we may think the pandemic may affect us for 2 years, I think we are all starting to learn that there will be much longer impacts of COVID-19 economically, socially, and also for our healthcare system. If we think of the COVID-19 disease stages, this framework is very helpful in our understanding of what happens acutely, but also what happens long-term. And if you look at the graph, you can see the triangle is showing the acute viral response phase. And this is when patients present with symptoms that seem like anything from a common cold to a pneumonia, and they come to hospital and a number of laboratory tests start to suggest that they have certain impacts of the virus on their white blood cells, on their coagulation system, essentially multi-systemic effects. And when COVID positive, they move into acute therapy. And as many of you have seen, these large randomized trials that have been completed rapidly over the past year have really helped us understand what works acutely and doesn't work. And we now have a number of therapies that we can offer that are effective when patients are hospitalized with COVID-19. Now, if we move to the center of the slide, you'll see the pulmonary phase reflects the issues that occur in the lungs that can appear like pneumonia, but certainly lead to hypoxemia and often the requirement of mechanical ventilation. And at this stage, we see that not only is there an infectious etiology, but there's a host response to this acute infection that has an inflammatory response. And the impact of widespread inflammation is observed acutely, and many of the therapies actually treat inflammation to improve acute COVID survival, but the inflammatory response continues beyond that recovery phase, and it can lead to long-term sequelae associated with the COVID-19 infection. So we've spent a lot of time in the past year trying to understand which therapies can minimize the viral response phase and minimize the host inflammatory response to the virus. Now, we talk about wave 1, 2, and possibly 3 in terms of infectious peaks, but there are also other ways to think about waves of COVID-19, which are essentially the impacts on patients and also the healthcare system. So in March of last year, in April, we were really focused on minimizing patients afflicted with COVID, which we still are today. But in doing so, we stopped patients who had other conditions from coming to hospital. We asked them to stay at home, and we tried to deliver healthcare over the telephone. That meant that a lot of patients stayed home, and their usually treated illnesses built up to a point where when we could see them in hospital, they were far past the point we usually would initiate some other therapies for them. It also led to people who have a need for counseling and support groups to no longer have such support groups. And essentially, the impact of wave 2 is on the impact on our healthcare system, resources for the people who need acute care, but also we have created a backlog of people who need regular care. And then, as we'll hear later today, there are many unexpected consequences of asking people to lock down at home across the life course from childhood to the elderly. When we think about the long haulers, this is the term used to describe the long-term implications of COVID-19 infection, like a long haul truck driver. We observe that patients who are affected with COVID-19, up to 1/3 of them can have long-term cardiorespiratory symptoms, and a larger proportion of COVID-19 patients have 5 common symptoms, and at least one is present in over half of patients affected by COVID-19 longer term. And these include chronic fatigue, headaches, problems with cognitive function such as concentration, hair loss, as well as ongoing shortness of breath or dyspnea. And in this nice systematic review meta-analysis, you can see that there are many other systems affected by COVID-19. It is thought that perhaps that prolonged inflammatory response has impacts across these systems, but these are all being investigated now. So we are going to learn more about the long-term impacts as studies get up and running and follow patients longer term. When we think about the cardiac complications, first of all, we can think about the people who seem to have worse outcomes when affected by COVID-19. These are often people who have pre-existing conditions such as obesity, high blood pressure, diabetes, or prior cardiovascular disease. If they get infected with COVID-19, they have a worse prognosis because their starting point is at a lower level of health than people who do not have these pre-existing diseases. The other features of the acute infection include, as I mentioned, inflammation, but also a systemic coagulopathy, essentially the inflammation incites a prothrombotic environment, meaning that small blood clots are formed and can travel throughout the veins as well as the arteries and cause significant impact in terms of causing myocardial damage, but as well strokes. These can be acute strokes or silent strokes, as well as blood clots in the lung that affect ventilation and often require patients to go to the ICU. So there are the acute complications of COVID, and the impact on the heart includes an inflammatory impact called myocarditis, acute heart attack, the left ventricle not pumping called a cardiomyopathy, the electrical system of the heart affected causing arrhythmias. Some patients go on to have a fatal arrhythmia, and then the blood clots on the venous side can lead to deep vein thrombosis and pulmonary embolism. So there are many complications that can be called cardiovascular complications of COVID-19. Now, when we look at in more detail exactly what happens, I mentioned that there are people who come into hospital already having established cardiovascular disease. These patients are designated to be high-risk patients. And then there are people who have never had cardiovascular disease who then are at risk of arrhythmias, cardiac arrest, heart attacks, blood vessels dissecting, high blood pressure that can't be controlled, and a more severe type of heart attack. So we have all of these potential presentations of COVID-19, and certainly when we see patients in hospital presenting with one of these conditions, they are tested for COVID-19 because we think it could play a role in tipping people into these severe acute conditions. And when patients are hospitalized, they either are admitted to the ward and they're given supportive care such as oxygen, their vital signs are measured regularly, and they have a number of tests to determine what the cardiac impact has been on them, in addition to the lung or pulmonary impact. If patients are not stable, they go to the intensive care unit for mechanical ventilation. If we think about the heart, a common test done in hospital is the echocardiogram. This can show us and has told us that in series of patients with COVID-19 who are stable enough to have an echo, that many patients have pericardial effusions, that means fluid around the heart. We have patients with right ventricular dysfunction, left ventricular dysfunction, and global ventricular dysfunction that can lead patients to have congestive heart failure on top of the pulmonary infiltrates due to COVID-19. When we look at the predictors of death in hospital, many patients who have cardiac injury have a higher death rate, and the essentially the relative increase in death after suffering a cardiac injury is 6-fold. So if this occurs, patients have a much higher mortality rate compared to people who do not suffer a cardiac injury. And you can see the mortality rate is almost 1/4 of patients who have suffered a cardiac injury. If we go to look at a multivariate model where we put all of the different features patients may present with and the features that they develop in hospital, again, this points to some of the risk factors: older age, history of heart failure, a severe impact on the cardiovascular system, acute respiratory injury, and then the presence of cardiac injury. I skipped over the ethnicity in this American study. Hispanic ethnicity is a risk factor for mortality, but I'll come back to that because that is a feature that has been observed in many countries around the world. Now, what about the brain? When we say cardiovascular, vascular means arteries, which mean they can go throughout the body. And one of the most impressive impacts of COVID-19 occurs in the brain. And actually, it appears as though COVID-19 causes vascular injury. So what this shows here is an MRI of the brain. On the one side, we see a normal MRI of the brain. And then I've pointed out an MRI scan that shows what we call high white matter hyperintensities. These are signs of brain ischemia. And on the other side, you see a black area, which is the outcome of an acute ischemic stroke or infarct. And these outcomes occur in patients affected by COVID-19. So although we know patients may present with acute stroke due to COVID or develop a stroke in hospital, these are strokes that we often will say are significant strokes, including injury or paralysis to the face, weakness of the limbs, difficulty with cognition. But there is also a large number of patients who have what we call silent brain infarctions or strokes that they didn't know they had that could only be picked up by an MRI. And in fact, there may be patients who've been discharged from hospital after COVID-19 who in fact have some brain injury that they are not aware of and has not been assessed because MRI scans are not routinely done unless patients have symptoms or a high suspicion on the part of the doctors. Now, if we think about the systemic impact of COVID-19, I mentioned that there could be ischemic stroke. There can also be bleeding strokes in the brain called hemorrhagic strokes. There can be tiny micro bleeds in the brain as well. So much of our therapies have been focused on preventing blood clots that then can break off and go to the brain, but also they are focused on preventing inflammation that can also affect arteries in the brain. And we're only now learning what the impact of systemic inflammation will have on cognitive function. And I know Dr. Kaplan will spend more time on the mental health impacts of COVID-19. Suffice it to say, there are many impacts, and one of the features that's most commonly reported by COVID-19 survivors, in addition to fatigue, is either difficulty coping with day-to-day activities that they used to do without difficulty, as well as depression. And these appear to be more commonly reported in women compared to men. Next, if we move to the ethno-racial disparities in cardiovascular outcomes amongst patients affected by COVID-19, some of the earliest data emerged from the United Kingdom, where they, in large data sets linked to the National Health Service, were able to demonstrate that patients of Afro-Caribbean origin or South Asian origin, primarily originating from the Indian subcontinent, had higher cardiovascular outcomes compared to their non-white Caucasian or the non-white control group, in large part white Caucasians. You can see that these are significantly higher across the board for myocardial injury, heart failure, atrial fibrillation, blood clots, and mortality. And these persist after adjusting for socioeconomic status, existing risk factors, pre-existing cardiovascular disease. So it's really led us to try and understand what is it about certain populations that place them at higher risk of getting COVID-19. Could be the way that they live and work, or there could be some innate biological difference. And the second question is, why are their outcomes worse if they are getting to hospital and receiving the same care as everybody else? When we look within the Greater Toronto area, data from Toronto Public Health also shows that non-white ethnic groups, in particular Black individuals as well as South Asian, have a disproportionately high infection rate of COVID-19 compared to people of white Caucasian origin. So essentially, they have a greater case rate compared to the actual number of people who live in that region. And so this is a first indication that within the Greater Toronto Area, we also see this ethno-racial disparity in terms of first getting higher infection rates, and now work is being done to understand if outcomes are different depending on ethnicity in Toronto and Canada. And when we think about racial disparities, they can affect outcomes in many different ways. I have the shining the light on vulnerable populations cartoon because vulnerable populations have higher risks of chronic diseases pre-COVID, and now we layer on top of that an acute infection that then exacerbates some of their existing health disparities. And then we add to that a few other features, and that is accessing healthcare may be different due to mistrust in the system, due to not feeling like they should go to hospital and miss a day of work because they may not have health benefits. And now in the post-COVID world, where it's difficult for patients with COVID or COVID survivors to navigate our health system, it will be even more difficult for these certain vulnerable populations to do so. COVID clinics are just popping up now, and really doctors are learning rapidly about the long-term sequelae. Clinics are popping up, maybe cardiac and other types of rehabilitation is required. And how do we get vulnerable populations to make sure they access this type of care will be an additional challenge and will require people to consider them in every aspect of planning. And on that note, Public Health Agency of Canada has highlighted the issues with respect to the high risk groups. They have nicely outlined in this graphic that indeed there are the structural determinants of health, which are understanding of social determinants of health. There are additional issues of facing stigma and discrimination for essential workers who have to go to work, but then are criticized for, going to work or carpooling with 5 or 6 other people. There are impacts on social cohesion and connectedness, depending on socioeconomic position. And all of these factors then can affect across the board, not only biological manifestations of various aspects of diseases, but also psychosocial factors, keeping healthy behaviors and accessing the healthcare system. So we think about the vulnerable populations, they have differential exposure, differential susceptibility, and possibly differential treatment. And time will tell if that's the case. Ongoing research will demonstrate that. So just to wrap up, because we have some exciting presentations ahead, COVID-19 has changed the way we live and work. We are learning how to care for COVID-19 patients in acute care, and now realizing that COVID-19 has a long-term footprint or imprint. And this can be multi-system. It can involve the cardiovascular, respiratory, neurological systems. Cognitive function may be related to that silent vascular brain injury. And certainly there are mental health impacts of COVID-19, both for patients who developed it, but also for people they live with and the society at large. I've shown or highlighted the ethno-racial disparities in cardiovascular outcomes. And I think we have many future questions, but one of those questions are, how will we as a health system prepare to care for COVID-19 survivors as outpatients? And we have to think about the unique circumstances faced by non-white populations. So I'll stop there, and I thank you for your time and attention.
Dr. Anand, thank you so much for a super fascinating talk. It was really interesting to hear your overview of the multisystemic effects of COVID. I think it's both organ systems and social systems that are affected. So you gave us a great overview. I'd like to remind our audience to post their questions in the chat so that we can take them up in the open forum later on. And in the interest of time, we can move on to our next speaker. Thank you.
Thanks so much, Anastasia. Next, we're pleased to introduce at this time Dr. Alan S. Kaplan. Dr. Kaplan is currently a senior clinician scientist, chief of research at the Center for Addiction and Mental Health in Toronto, and a professor in the Department of Psychiatry at the University of Toronto. He's also director of the Institute of Medical Science, School of Graduate Studies, and Faculty of Medicine. He was the inaugural Loretta Ann Rogers Chair in Eating Disorders at the Toronto General Hospital and is currently senior scientist at Toronto General Research Institute. He received his medical, psychiatric, and graduate school training at the University of Toronto and has worked in the field of eating disorders for over 30 years, lecturing widely on various topics in the field, published over 150 peer-reviewed articles, 2 books, 50 book chapters, and over 200 abstracts. He's the past president of both the Academy for Eating Disorders, the largest organization of eating disorder professionals in the world, and the International Eating Disorder Research Society. He's been a continuously funded peer review investigator since 1992 and has received grant support from the National Institute of Mental Health in the USA and the CIHR in Canada. Today, he'll be speaking to us about another form of PPE, psychological protective equipment. The public health restrictions imposed on all of us to limit the spread of COVID-19 creates a perfect storm for the emergence of mental health disorders. The requirement of physical distancing, disruption of usual routines, isolating and removing ourselves from social supports, including friends and family, financial anxieties, lack of certainty about the future, combined with information overload, rumors, and misinformation, create the antithesis of a mentally healthy environment. Rather, it creates fertile ground for the emergence and increase in anxiety, depression, and substance use. This talk will focus on aspects of self-care that can act as personal psychological protection. These strategies involve first, taking care of one's body, making sure one gets adequate sleep, regular physical activity, healthy nutrition, while avoiding substances, especially alcohol. Second, taking care of one's mind and psyche, involvement in productive activities, focusing on positive thoughts and developing a regular routine, and most importantly, staying connected to others. Physical distancing is required, but it shouldn't be confused with social distancing. Without further ado, let us welcome Dr. Allan Kaplan.
Thanks very much, Chris. I appreciate that. And I've got to update my my bio. So those are, Chris mentioned a number of positions. I'm currently at Center for Addiction and Mental Health and a senior scientist there. I had been director of IMS and previously vice dean for graduate affairs. So let me share my screen. Technologically somewhat challenged. Hopefully this works. Okay. Let's go to Zach. People see that? Thumbs up. Okay, I'll assume that it's okay. And I just got to back it up. Okay, so I'm going to focus, and it's picking up from Dr. Anand's comments on the mental health implications of COVID, of which there are many. And you know, it's important to remind ourselves that mental illness is associated with inflammation, a number of different disorders, especially depression and anxiety in the limbic system. So I'm going to focus more on the psychosocial aspects of an impact of COVID on mental health, but we must understand also that there's an underlying neurobiology going on as a result of the virus causing the inflammation that was just described in the brain. So this is a powerful visual portrayal of the sense of frayed disconnection and rupture that has occurred in the lives of individuals during COVID. With the sense that, and I know this from my own experience as a clinician and amongst friends and colleagues, a sense that many people are hanging on by just a thread. So what I'm going to focus on is how can we go forward to repair these connections and limit the damage that's been incurred. And we'll talk about that right now as part of my presentation. So a simple definition of mental health that I like is the capacity to love, work, and play. And COVID has dramatically impacted all these areas of functioning. And it's affected all of us, not just a few. We're all experiencing the stress that it has caused in our professional life and our ability to play and to love. Interesting, this past week, as all of you know, marks the 1-year anniversary of COVID-19. So how has COVID impacted our mental health? And to cut to the chase, it's not a pretty picture. We now have a second pandemic to deal with, a pandemic of psychological pain and mental distress, which I believe will have significant ramifications that go well beyond the viral pandemic itself. So the public health restrictions that have been imposed to limit the spread of COVID-19, and as Krish alluded to this, really create a perfect storm for the emergence and exacerbation of mental health disorders. These include, as we all know, disruption to daily routines, physical distancing, and just to emphasize again, that's not the same as social distancing. We should discourage people removing themselves socially if they can do that through technology. But the physical distancing leads to social isolation and loss of social supports. There's the impact on people's financial state, which is very significant and has increased levels of anxiety across the board. One thing that people don't talk about is the exposure to anxiety-provoking media. This leads to information overload and a lot of misinformation. There's uncertainty about the future. One can't plan at all for the immediate term and even for the long term because of COVID. And then obviously the fears of contagion may increase psychological distress and symptoms specifically related to the physical health impact. So all of this really creates the antithesis of a mentally healthy environment. Rather, it creates fertile ground for the emergence and increase in anxiety, depression, suicidal ideation, disordered eating, the area that I work in, and substance use. As well, relationships become stressed, leading to potentially serious marital discord and family disruption. So recent surveys, and there have been many, have found following data statistics, 54% of over 1,200 respondents who responded to a community survey rated the psychological impact of the outbreak as moderate or severe on them and their families. 68% of respondents in the community on a screening instrument screened positive for an anxiety disorder. Pre-COVID, this figure has always been around 18 to 20%. There's been a significant increase in alcohol use, including binge drinking from pre-pandemic use. Up to 40% of people report increasing their alcohol intake. 25% of individuals report an increase in depression during the pandemic, and 30% an increase in disordered eating, binge eating, purging, or significant caloric restriction. So this is a slide that reminds us that we need to be cognizant and aware of the impact of COVID on suicidal ideation and behavior. There's evidence that suicidal behavior has increased significantly during the pandemic, and that this increase is likely to be present for a long time and actually peak later than the actual pandemic itself. As shown in this slide, and I've already mentioned, COVID-19 has brought with it uncertainty, social isolation, economic problems. This impacts vulnerable people and has a greater impact on vulnerable people who have less resilience than others to deal with these stressors. And the vulnerable people include those who have pre-existing psychiatric disorders and who have suffered the loss of a loved one or a friend. In such individuals, this can lead to an exacerbation of their pre-existing condition or the expression of a new mental health disorder, as I said, related to the psychosocial impact, but also the impact of the virus directly on the brain. And all of these, the emergence of all of these disorders, whether it's depression, anxiety, alcohol, or other psychiatric conditions, increase and raises the risk of suicidal ideation and suicidal behavior. So this pandemic, as we all know, has triggered associated triggers that have occurred. I've already related to this: isolation, unstructured time. The media impact is not often spoken about. I think many people have expressed to me, including people that I see clinically, that the constant counting of cases, counting of deaths, counting of outbreaks, I mean, all of this that occurs every day in the media has had a significant impact in a negative way on their mental health and their functioning. And there are significant changes to lifestyle and global stressors as well. So if you look at people who have eating disorders, COVID can trigger an increase in eating disorder symptoms through at least two pathways: an increase in depression and anxiety symptoms, and then coping with those through their disordered eating behavior, or through eating disorder specific cognitions and behaviors, which leads to a vicious cycle of increased level of symptoms as shown here. And despite efforts to restore psychological balance, this kind of vicious cycle of increase in symptoms and then attempts to deal with that by relying on symptomatic behavior. Just as an example that people don't often think about, I hear all the time, people with eating disorders are infamous for never wanting to look at themselves in the mirror. They don't see themselves accurately. They see themselves as overweight and fat. And that's a real disturbance in interoceptive awareness, which our group has shown through research through a hyperactive insula. So that's not an imagined thing, and it only occurs for their own estimation of their body, not others. And staying on Zoom calls for hours for somebody with an eating disorder and significant body image concerns just feeds right into their disorder and exacerbates their symptoms and their focus on weight and shape. So how do we mitigate the effects of COVID in trying to do some kind of damage control? So the first is really to take care of one's body. We heard previously about all of the medical complications associated with COVID, and we need to be very aware and hypervigilant in terms of how we treat our bodies during this period. There's definitely a need for regular physical activity, adequate sleep, healthy nutrition, and the avoidance of substances, again, especially alcohol. But we also must take care of our mind and our psyche. That is, protect our mental health. This is the PPE part of the talk. And I would say the most important thing is to stay connected to others. Use technology to maintain social connections. This is so important because the worst thing for people who are emotionally and psychiatrically vulnerable is to feel isolated and disconnected. One should involve oneself in productive activities, if at all possible, focus on positive thoughts. Our routines have all been disrupted. And so trying to develop a regular routine during COVID is a challenge, but certainly worthwhile trying to do. One should lean on one's personal beliefs and faith for support and look for ways to give back to the community. All of these will help mitigate the impact of COVID on emotional functioning. Some of my patients have found it extremely helpful to get a pet dog or a pet cat during this period. It helps with the isolation. It imposes a routine because they have to take care of the pet. And it allows them to get out and be more active. A simple thing like that can make a huge difference in somebody's life who is otherwise quite isolated. So how do we build resilience is really the key. How do we build in people the ability to protect themselves from some of the risks that we've talked about? And I would say that one needs to create clear boundaries in 3 domains, and that this will help create resilience. The first domain is temporal. Very important to carve out stress-free periods away from work, time for relaxation and non-work related activities. This is especially difficult as most of us are working from home. And so the period that divides work time from non-work time was usually determined by when we arrived in the office and when we left for home. So that demarcation is no longer in existence. And we have to be proactive in really blocking off time away from work and non-work related activities. There's a need for cognitive boundaries. So we need to compartmentalize our cognitive load. So this is serial monotasking. It's kind of the opposite of multitasking. We're all overwhelmed every day by stimuli, by information, and it's very difficult to keep track of everything that's going on in our lives, in our world. And so I would say we should try to focus on one thing at a time, as opposed to what we're all used to doing, which is doing many things at the same time. There's a need to exercise mindfulness, develop mental agility, the ability to pause, step back, reflect, shift perspectives, create options, and choose wisely. And then there's obviously the physical boundaries. Really important to remove oneself from the work environment, even if it means just getting up in the room you're working in at home and going to another room to do something else that's not work related. We need to do this every day to create a healthy space and a healthy distance from work, and to be able to focus on the rest of our lives, the rest of what we do in our life. So at a practical level, to cut to the chase, make time for well-being activities. And it differs for each person, how we define a well-being activity. But these are examples of those type of activities: mindfulness, meditation, yoga, exercise. These are all important activities that help to keep us emotionally balanced and well. And they should be part of your daily routine and be, when you construct your schedule for the day or the week, should include every day some kind of well-being activity. We need to create more flexible work schedules, and really important to take time off away from the screen and the computer every day. And finally, as I've emphasized already, the need to connect with coworkers, connect with friends and colleagues. It requires an effort to do that, because we're not regularly interacting with our colleagues and friends like we would in a normal situation. We're not seeing people regularly because we're not at work. And we all need to make an effort to connect with our coworkers, our friends, our colleagues, go for a walk, speak on the phone, arrange a Zoom call, whatever it might be, so that we all feel socially connected. So I'll stop there, and I want to thank you for all your attention, and hopefully be able to answer questions at some point during the afternoon.
Thanks so much, Dr. Kaplan, for your wonderful presentation. On the topic of questions, we're getting some wonderful questions in the Q&A section on Zoom, but we'll hold them to the end in the open forum section, where all the panelists and Dr. Angel will be able to go through the questions together. So now, without further ado, we can have Anastasia return to introduce Dr. Reithmeier.
Thank you so much, everyone. So up next, we have Dr. Reinhart Reithmeier. He is a real champion of graduate student education. He is a professor in the Department of Biochemistry at the University of Toronto and is known for his research on membrane proteins in human health and disease. He is an award-winning lecturer and graduate mentor, having taught introductory biochemistry courses to over 1,000 undergrad students every year, and he also teaches upper-level graduate courses. He was chair of the biochemistry department from 2002 to 2013 and special advisor to the Dean of Graduate Studies on graduate skills development and engagement from 2015 to 17. He served on the CIHR panels and as a CIHR delegate, and is currently president of the Royal Canadian Institute for Science, an organization whose mission is to bring science to the public. His leadership was recognized in 2012 by election to the Canadian Academy of Health Sciences, and he spearheaded the 10,000 PhDs project, which is a study on career outcomes of PhD graduates. So clearly, Dr. Reithmeier is dedicated to the development and career growth of graduate students, which he will elaborate in his talk on 5 ways the pandemic has changed graduate education. So we have heard about the medical and cognitive effects of the virus on individuals, and now Dr. Reithmeier, we would be pleased to hear the challenges and strategies and how we're dealing with education in this new era. Thank you so much.
Okay, great. Thank you very much, Anastasia, and for the kind invitation to present a few of my thoughts on the 5 ways the pandemic has changed graduate education. People could probably think of a different 5 ways. There are many ways that the pandemic has changed our lives, as we've just heard, of course. So I'll just go through the 5 in the interest of time. And really, I want to give maybe some examples from myself or what I've heard, and maybe really focus on some action points, how we're trying to deal with these things, like Dr. Kaplan has said about the mental health thing, about taking action. So the first one, probably obvious to a lot of people, is here we are on Zoom. Remote learning is here to stay. So as Anastasia mentioned, I teach biochem 210 in Con Hall every fall to over 1,000 students, and kept thinking over the last year, does it make to have 1,000 students together in Con Hall during even regular flu season, where they have to come up from all over the GTA to sit in Con Hall? It's a beautiful place, but to listen to me talk about amino acids for 50 minutes. I think not. So we're probably going to, in this fall, deliver the lectures as we've done this year remotely. What we're going to do is we're going to have an army of teaching assistants, mostly graduate students, give them a chance to get engaged in teaching, to do small group learning sessions in person, if we're allowed to, in the fall of 2021. Many research seminars have switched to, again, virtual in almost every department in Temerity medicine. A couple of consequences there. Participation has increased. So instead of, again, grad students having to come all the way down from Sunnybrook to sit in 2172 and MSB to listen to a couple of students present, they can do that from their desk or from their lab bench. It's been pretty amazing participation rate. But as already been pointed out by Dr. Kaplan, what's really missing, and the students have told me this, is the personal connection, and we have to work on rebuilding those connections. The second point is that graduate student voices need to be heard, and we've heard a lot from them over the pandemic. So Temerity Faculty of Medicine had a project called Voice of the Learner, where we've engaged with medical students, faculty, staff, grad students, etc. And the results of those surveys have really driven kind of change in terms of concerns that our learners have had at all levels. Alan Kaplan has been a real leader in GLSE, and we have a supervisor evaluation survey going to roll out very shortly. Alan will be very happy to hear that. So students will be able to actually give feedback on their supervisor experience, and again, we'll make the adjustments as needed. One project that I worked on, I'll mention at the end, is a Healthy Labs initiative. And we heard from postdocs, and one of the quotations that I remember that just sticks with me from the meetings we have with the postdoc group is, I feel invisible. Postdocs often go into labs, they work really hard, developing their career, but they're not really part of the departmental culture. And so we're going to create in Temerity Medicine a postdoc academy to lend support to our graduate students across Temerity Medicine. I think it's a great, exciting initiative. And again, Alan has talked about this already. The third point I want is we need to build resilient community groups. And I think Massey is one example of that. So I hope, you know, the junior fellows have been active in Massey, even though it's remote. We all miss, you know, those interactions we have, whether it's around the, you know, the dining table, you know, or at group meetings in the library, etc. So we're all missing those. But again, Massey is, you know, that community is really, really important. And what we've done again in Temerity Medicine is we've created Temerity Medicine Connect. So it's again a virtual way of connecting with for students to connect with each other through their various departments. That's where they've told us they feel most at home, is those departments. But also to connect with alumni. And because again, I'll come up, this point will come up in a couple of seconds about their, you know, future careers, etc. So the Temerity Medicine Connect gives opportunity to students and alumni to connect. And we're building mentorship programs through that platform, and also to do networking events. Again, it's a virtual platform, and it's, you know, we're building it up. IMS was the first department, and other departments, you know, are joining very quickly. I think physiology was next, and biochemistry as well. But all of the graduate departments in Temerity Medicine will connect. And then just back to the promoting point number 4, a healthy lab culture. So this is really, really important that, you know, the lab, especially if you're in a, you know, wet lab like in biochemistry, you know, wanting to come into the lab is really important, because you connect with your colleagues and peers, others in there. Over the last year, we've been able to maintain research at about 50% capacity. So students have told me, most students have told me they really look forward to spending some time in the lab. Of course, they're 2 meters apart, they're wearing masks, and, you know, never washed their hands more frequently, and sanitized equipment, etc. It's been a real learning experience for all of that, but that's been a really, what I've been hearing, a really positive thing in terms of continuing to, you know, move their, you know, vital research forward. The healthy lab culture is certainly a priority for the School of Graduate Studies, and they're starting to work on programming to develop that. Again, in Temerity Medicine, I'm working with the Center for Faculty Development. So this is focused on faculty to instill a higher sense of professionalism in graduate supervision and lab management, because we as scientists have never really been trained as lab managers. We just sort of mimic, you know, what we learned in our own pathways, or reject what we've learned if it wasn't a good experience, but it's not really the best way to go. So we want to really enhance professionalism in that, and we're going to put together some programming to do that for the supervisors, so that things like graduate student mistreatment, which unfortunately does happen, etc., or there are toxic environments, you know, we eliminate those. There's no room for those in any educational institution, especially not at University of Toronto. So point number 5 of my quick, you know, 5 points is, you know, to support diverse career choices. And I've been working, you know, as Anastasia has said very kindly in her introduction, on promoting these diverse career choices. We have good outcome data that not everybody becomes a professor necessarily, and that's what I believe is not necessarily a bad thing. There are lots of things you can do with a PhD out there. We all know that the pandemic has increased slightly times to completion. There's data from the School of Graduate Studies. It's been 1 or 2 terms, so it hasn't been, you know, devastating. And students have taken the opportunity to build their skill set during that time. At least hopefully most people have. You know, learn that, or even learn how to play the piano. That's, I know a lot of students have said, I've finally got time to, you know, work on some of my other interests. Well, since I can't go into the lab all the time, which has been great. That again reflects on Alan Kaplan's really, really great remarks. I was on a panel that was organized by the Council of Canadian Academies, and it's called Degrees of Success. And it was really about PhD transitions from academia into whatever is next for them. And, you know, it's a long report. If you want to read it, again, it's called Degrees of Success. Just Google that with Council of Canadian Academies, you can find that report. So a couple of points just to highlight is that, PhDs are increasingly are playing a critical role in the Canadian economy, not just in academia, but in beyond. But they're underutilized, really, especially in, industry, government, and, the public sector. So there's still lots of work to do in that regard. So I'm, mindful of the time. Speaking of mindfulness, Alan, learned that as well. I'm spent some time myself thinking deeply about my career and how I got here and my own white privilege, etc. And it's been, I've actually, I think I'm going to come out of this pandemic, I think, stronger than I went in. But it did take a lot of effort and help from others, including great people like Alan Kaplan. So again, thank you very much for the invitation. And again, I think people could come up with a different list of 5, but that's my own reflections over the last year. I hope it's helpful to some people. Thank you very much.
Thank you so much, Dr. Reithmeier. It was great to hear all your comments on the 5 ways that the pandemic has changed graduate education. So I think now moving forward, we can go into our open forum session and finally address all the questions that have been submitted in the Q&A. So that will be hosted with Dr. Angel. Great. Dr. Angel, thank you for joining us on screen. Yeah.
Yes, I'm on screen now and unmuted.
Yeah.
Thanks very much, Anastasia, for the introduction, and thank you to the speakers for brilliant, concise presentations generating questions. And what I'll do is read them as they've come in. One is from Anita McGowan, and she writes, Dr. Anand, thank you for your outstanding talk and inspiring work. Would you kindly expand on your view of the implications of all the undiagnosed complications associated with COVID? In our health system, is our health system going to be confronted with many years of diagnostic and treatment burdens as these complications are revealed? Or do you believe that many of these undiagnosed problems will stay undiagnosed? Thanks very much.
Thank you. Thank you for the question. It's a great question. I think that the first point I will make is we think there is a long-term effect of COVID, the long haulers. What we don't know is how long that lasts. Does that mean that patients have a chronic illness forever? Or does it mean over a period of months to a few years, these impacts on their health can resolve? We don't have a long enough follow-up to know the answer to that question. The second point I would make in response is there will be an impact on the healthcare system that was already, very stressed in terms of getting patients in for diagnostic tests and surgeries, etc. And now we add to that a layer of additional diagnosis and need for testing and need for rehabilitation. So there will be a system impact. There is the individual impact of COVID-19. We don't know how long that will last. And it may be that some people rebound faster than others. And this will require future research. And I know that there are a number of calls for applications of these very types of studies, population studies, to examine and characterize the long-term effects of COVID in the population and in certain high-risk groups. I mentioned some ethno-racial high-risk groups, but there are others, those who have immune-compromised systems, those with existing chronic disease.
Thank you. And here's one for Dr. Anand again. This is one from Dr. Anonymous.
Dr. Anonymous.
Thank you for your presentation. There's much information in the news about the AstraZeneca vaccine causing blood clots. This has led to even more mistrust in vaccines by the public than before. Are you able to comment on this news and what to tell non-STEM folks who are skeptical?
Sure. First of all, my disclaimer is this isn't medical advice. But the second point I'd make is that there is a natural incidence of venous thromboembolism, otherwise known as blood clots, in the population. So we see an increased risk in patients who are older or have risk factors such as immobility and other diseases. So we know that there's a background level of blood clots. And when we think of the millions of people who have received vaccines, such as the AstraZeneca vaccine, then, and we actually divide the number of blood clots observed by the number of people who have received the vaccines, we don't see that the rate of thrombosis with the AstraZeneca vaccine is higher than the baseline rate of venous thromboembolism population. So long story short, as someone who treats patients with blood clots and as a member of societies who review and pore over the data, we don't think there's any excess risk of blood clots with the AstraZeneca vaccine. And so I agree with almost every other physician I know. If you're offered or have the chance to have a vaccine, have it.
Excellent advice. Here's one for Dr. Kaplan from Anita. McGann, Dr. Kaplan, thank you so much for your great talk. Do you have a sense of what the long-term mental health consequences of COVID might be, both directly as a result of the brain fog that occurs among many COVID sufferers, and indirectly as a result of the social isolation that you emphasized? Are we in for a decade or more of setbacks? Thanks again.
Yeah, thank you, Anita, for that question. I think research is going to give us the answer to, the first part of your question. There certainly is cognitive implications to COVID, and they're probably a direct result of the effect of the virus and inflammation on the brain. I think research has to be able to tell us what the pathophysiology of that process is and how we might mitigate it. But there's no question that we see people who are long past the acute stage of illness, yet they still complain of and exhibit cognitive dysfunction, cognitive deficits, and of what you are calling quite appropriately brain fog. But I think in terms of the psychological impact, the way I view it is that COVID-19 has imposed on the entire world a massive trauma. That's the way I see it. This has been traumatic for just about everybody who has been on this planet. I mean, it hasn't spared anyone. And we know when there's trauma, there's long-term implications. So one could look at what's going to happen down the road, almost like the development of a population-based PTSD syndrome, post-traumatic stress disorder, where people develop symptoms associated with the trauma. They may have associations to what happened to them during COVID. They may become hypervigilant, have nightmares, flashbacks. I mean, that's what occurs in any traumatic situation, and I don't see why it should be different, even though this is on a global scale. I think the other factor that we have to take into account is a kind of paranoia that's developed in all of us. I mean, just take a walk on the street, in the sidewalk, and your first impulse when you see somebody now is to separate yourself. This is a person who potentially could kill me. I mean, when would we have ever had thoughts like that before? Never. we would be attracted to somebody who's walking by us. We would say hello, ask how they are. We would approach them rather than distance ourselves from them. I think that is going to be a difficult thing to overcome. I know myself, it's an immediate reaction now. As soon as I see somebody walking towards me, I get out of the way. I go across the street or I walk on the street. And so that person becomes potentially dangerous for us. That's, I think, over the year and a half, or maybe even 2 years of COVID, and I hope it's not true, but it's almost like it's become hardwired in our brain. And that we're going to have to work really, really hard to develop basic trust again in people, people we know and, strangers. I'll tell you a personal story that really struck me. So I'm lucky and fortunate to have 5 grandchildren. The 2 youngest are twins from my middle son, and I go over there frequently with a mask and usually watching them from the door. 2 weeks ago, I went to visit them. They're now 18 months. And my son asked me if I wanted a drink. So he gave me a glass of water. And I took my mask down to have a drink of water. And the little boy started to cry. And he ran away from me. He had not seen my face in his entire life. It was scary for him. His image of his grandfather was this masked person, and the only thing he could recognize were my eyes. And that really struck me, that we're in young people, they are developing a different sense of who we are, facial recognition, which is so important in the development of relationships and basic trust. And I have to say that disturbed me to think about that, because he that's the way he's grown up. That's virtually his entire life has been within the COVID pandemic. And it's normal for him to see everybody walking around masked. And how is that going to impact on young people as they grow older? So these are, reflections that we can all think about, but they do damage to people, especially young people. And I would worry most about the younger people in our community who are, have been exposed to this at a very impressionable age. The impact that it's had on their schooling, on job prospects, everything has been affected. And we know that young people are highly stressed as a result of COVID. So those are some of my thoughts, contemporaneous thoughts in response to your question, Anita.
Thanks very much, Alan. And now, Reinhart, there's a question for you, of course. And now, has there been a great uptake among U of T alumni in assuming mentorship roles?
Okay. Yes, in fact, they are more than willing to participate. So over the years, when our professional development classes we run in biochemistry now and other departments across Temerity Medicine, we have reached out to alumni and asked them to participate in professional development activities, whether that be as a career panel, to help out in our courses, to serve as mentors, to serve as judges for various activities we have. They were more than delighted that we reached out to them, and they're very willing to participate back through their home department. It's been very, very gratifying. It's their way of really giving back to the university other than monetarily, which a lot of our recent graduates, of course, are not able to do with student debt, et cetera. Doing a PhD is, if you look at degrees of success, it's deferred income. I did a calculation myself, Abby, that it took me 15 years to catch up after my PhD to what I would have earned if I became a lab tech after my Bachelor of Science degree from Carleton. So there is an economic cost. Everybody knows that about going to medical school or law school or graduate school for sure. But it's been delightful. That's why we've gone to Temerity Medicine Connect to scale up our outreach to alumni, to engage them in activities within their own home departments where they really feel a kind of allyship and alliance. It's been more than gratifying.
Another question for you, Reinhart. Is there any estimate of how much U of T has lost from the point of view of research productivity due to the pandemic and halted lab research?
Yeah, I don't think we have that number yet. There has certainly been a delay in, getting work done to finish off a publication. Many graduate students, the final experiment has been, delayed. I think a lot of work that has been impacted significantly is, human subject research. If it's not, related to normal clinical practice, people don't have to come into hospital for that. So there's been a big impact on the grad side. I hear that. I know from my clinician friends that that's had a big impact, the face-to-face kind of thing. That also maybe Dr. Nankam, a lot of human subjects, are reluctant to come into a hospital setting, even for vaccination. I have to say that U of T has created the students will love this, a vaccination center in the old exam center, which is, a stressful place, Alan, for sure. But a lot of people who are coming into those clinics with like UHN Mount Sinai are delighted to come into the University of Toronto setting rather than to a hospital setting to get their like Pfizer or Moderna vaccine. So that's been a sort of you don't have to go to a hospital setting, you can come into this exam center. So it's been terrific, yeah.
I would just add, from the clinical research perspective, we have had to stop our patient visits in clinical trials and our observational studies. It's had a huge impact. So essentially put the brakes on doing those follow-up visits. So it's been very difficult across many of our trials. We've tried to convert and do follow-up visits over the telephone, but you can't measure blood pressure and do other things like that. So I also have some graduate students and young faculty writing their CIHR grants where the reviewer says, well, you need pilot data. You can't get pilot data in a pandemic and a lockdown. So it's really having a number of widespread effects in research and patient care.
Sonia, here's a question for you. If all patients receive the same level of care once they arrive in the hospital, why are the non-white ethnic patients suffering more from COVID? What's the possible mechanism?
Yeah, that's a great question. And I think it's something that will be researched. I don't have the full answer. A few comments, however. First of all, patients from high risk or vulnerable populations may delay coming to hospital. So they come to hospital at a later stage of disease where it's more difficult to kind of save them with the best therapies. That's one possibility. Then we could try and discuss why it is that people wait so long to come to hospital. That's a whole other set of reasons. In hospital, the patient care that we give at all our Ontario hospitals, for example, should be the same. Are there implicit biases where if you have, one ICU bed, you choose one individual to go to the bed and you think the other one may not merit the bed? That can happen. That are some of the systemic biases that we're just starting to talk about now in our healthcare system. We've certainly seen some very vivid examples of discrimination in healthcare against the Black community and Indigenous communities in particular. And then the third option may be that there is a different immune response where some people from different ethnic groups with a different set of genetic polymorphisms may mount a more aggressive inflammatory response or not. We still don't know. So I think we'll have a lot of future research studies to unpack all these possibilities.
Thank you. Dr. Kaplan, question here. Have you had any experience managing your patients virtually during the pandemic? And how effective is that in the management model?
Yeah, so I've managed virtually most of my regular patients I've seen remotely. And that's been the directive of CAMH quite appropriately to protect the comings and goings into the institution. I've had to see several people who got admitted to the floor at CAMH because they were so ill. So, that's as I would have otherwise. But the remote experience, I have to say, has been an interesting one for me. It is not the same as seeing somebody in person. And, you know, for me, especially because the vision, people I see, a lot of them have anorexia nervosa. They're quite thin. Some of them are emaciated. So I can't weigh them, obviously. And many of them don't want to put their video on. So I end up with having to deal with them just through audio contact. And that's far less than ideal because I can get a good sense of how they're doing just by how they look and what their nutritional state is. So that's been a challenge. And, you know, I think one can get used to anything. It certainly has opened up access to people. So I saw somebody who was quite ill and is living in British Columbia. So I did a consultation last week on somebody who was referred to me from British Columbia and did it remotely. Would not obviously have been able to see that person had I not gone to a remote platform and not somebody I had seen before. So I thought that was positive and opens up access for people who wouldn't otherwise be able to access specialty care in a tertiary care center. But, you know, psychiatry is, as I've said many times, the equivalent to the scalpel for a surgeon in psychiatry is the relationship. And you have to hone that relationship and build it so that it can do incisive work. And, you know, a dull relationship is like a dull scalpel. It doesn't work, It doesn't work very well. So it has to be vibrant. It has to be one embedded in trust and openness and transparency. And so all of those factors are much harder to establish, even in the short period of the COVID pandemic. When you're seeing people remotely, you are missing that kind of palpable connection that occurs between a distressed person and somebody who's offering emotional support and care. Those are some of my thoughts about the question. It's a great question.
Well, we're getting a load of questions that's outpaced our time available, unfortunately, which is frustrating. But here's the final one for the group. This is presented by Anastasia on behalf of Principal DeRosier. To all panelists, are there lessons for public health to have a holistic approach that would reflect the ethno-racial and mental health impacts that have now been revealed when we have the next pandemic? Here's a complex question. Are there lessons for public health to have a holistic approach that would reflect the ethno-racial and mental health impacts that have now been revealed when we have the next pandemic? Yes, Reinhart.
We're all students of history, and I'm not that optimistic that we will learn our lesson.
Yeah, and I would add that
Sonia, go ahead.
Okay, sure. I mean, there are lots of lessons. I agree, we could have learned a lot from history, but we don't usually pay attention, or we have a short attention span. With respect to public health, I mean, we can take a step back and think about the social determinants of health. You know, that includes prosperity, education, social connectedness, trust. And the groups who are most affected, although people are surprised, shouldn't be surprised, because these groups have high rates of everything anyway, pre-pandemic. And when we look, say, in our different vulnerable communities, including First Nations people, we can see that there are layer upon layer of determinants of their health, including as far back as colonization, residential schools, assimilation. So there are lots of lessons for public health. The pragmatic answer is, what can we do to improve things? From a clearly Public Health Agency of Canada perspective, maybe not have dismantled our pandemic preparedness response that was, dismantled, thinking this will never happen. Well, it happened. Things of that nature are important, but I do think that we've learned from this, and we realize that our usual public health messaging, it does not reach certain high-risk populations, that we have to tailor our messaging to the ways in which those populations communicate, which may be different languages, it may be different media, and it may be getting people who are influencers in those communities to make sure that they're communicating well.
Excellent summary. Now, Alan, you have the last word on this.
Yeah, just briefly, I mean, I think the pandemic's exposed very significant gaps and limitations in our healthcare system. I think one needs to take a step back and look at our healthcare system to be able to rectify some of the things that we didn't do so well. I think is going to have to take a public health perspective, as Dr. Anand has said, and look at our healthcare system broadly. And again, as I just talked about, improving access to care is a big part of that. So using the technology that we now have begun to become familiar with to improve access for underrepresented populations, those that aren't privileged enough to have access in their local communities, that can go a long ways to improving care. But we have to take a public health perspective and look at the overall healthcare system rather than just pieces of it.
Well, thank you very much. We have many questions that are worth considering, but time is running short and we must move on. But what we'll do is we'll assemble the questions and forward to them to you out of interest to see how you might feel about answering them in a different context. But I think we need to move on. So we'll thank you for this wonderful question period and move on in the program, which is now opportunity to invite a sponsor and supporter, a senior fellow and eminent scientist in Canada, Dr. Rossant, to have the spotlight for concluding observations.
So thank you, Bobby, and thank you for the speakers. I think this has been a wonderful set of talks. I have a few thoughts which have sort of come up actually during the panel discussion. But what was sort of obvious to me from all three talks is COVID is a disease, it's a pandemic viral disease, but COVID is so much more than that. COVID has just revealed so much, exacerbated things we know are wrong in our society, in our healthcare system, in our education system. And it's just brought the spotlight, as Sonia said. We've put a spotlight on many of the issues that we need to deal with. And they've been there all the time before COVID came along. So we talked about the groups who are particularly susceptible to COVID being those with pre-existing clinical conditions that are not being treated because for all sorts of reasons they don't come forward, racialized and vulnerable populations. We talked about the impact of COVID on mental health, exacerbating the ongoing issues around mental health, which again affect particular populations much more than others. We need to think, if COVID is putting a spotlight on these things, we need to really dig in and ask ourselves, what should we be doing? We didn't talk about it, but we know, of course, that one of the biggest impacts that occurred early in this COVID pandemic was the impact on the long-term care and our aging populations, the vulnerable populations who died in large numbers because we did not spend enough time thinking about how we want to look after our aging populations. So all these things, our problems, have been exacerbated and spotlighted by COVID. And even graduate education, Reinhart, you talked about all the things you're trying to do to make graduate education better. All those things were there all the time. COVID just makes it more obvious when you walk in a lab and you see that people are not interacting, when you see that the supervisor isn't there giving the mentoring advice. We really need to do things better. So lots of lessons to be learned. I'm more optimistic. I am optimistic. I'm not Reinhart. I don't think that we have not learned. I think we must learn this time. Things have changed. Some things will change forever. We're going to see more remote learning. We're going to see more remote healthcare, not bad things, because these are going to bring efficiencies and broader access to both learning and healthcare. So that's going to change. We're going to see scientists not traveling as much. We're going to stay home. That's also good for graduate education. There's a lot of positive things that can come out of this. But I do think that more seriously, we have to think about resilience. We've got to come out of this more stronger and more resilient as a society and a population. And all the little bits somehow, as Principal DeRosier says, we need a holistic approach that I would say goes beyond our healthcare and public health. It's a holistic approach to our society. How do we really make sure that we deal with all the issues to enable all the people who are most affected by COVID in different ways today? Those are the people who we have to help be more resilient for the future, so that they can overcome not just pandemics, but really be functional members and major contributors to the economic value of our society and all the other major challenges we're going to have to deal with in the years ahead. So I just wanted to also mention, because I'm president of the Gairdner Foundation, we've had a number of global perspective panels this year, some of them touching on COVID issues. And one of them, because there was a question that came up in the Q&A I'd like to quickly answer. Somebody asked about Medicago and the Canadian vaccine that's being produced by this company in Quebec City, and why haven't we heard more about it? Well, actually, we had them presented our global perspectives panel, and it is quite exciting. But the reason it's not made it to the front line is that they're just going into phase 3 trials. But in fact, the government of Canada in the vaccine task force has actually procured in future, if they are successful, the government of Canada has procured Medicago vaccine as one of the ones that would be used potentially in Canada. So they have got some, but you're right, there hasn't been a lot of publicity, and it's actually a really cool story because the vaccine is made not in animals or vectors or anything, it's made in plants. You can look it up. So at that point, I'd also just like to say that we have, the Gairdner Foundation has another global perspective panel coming up on the 30th of March. And this is around vaccines and vaccine confidence, which is another issue we haven't touched on, but it deals with many of the same issues we've been talking about. It's called Moving Forward with Confidence, and I think it's going to be a great panel. We have Heidi Larson, who heads the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine. We have Rina Rappioli, who's head of vaccines at GSK. We have John Tenkovsang, who is the head of the African CDC. So this is going to give us a global perspective on where we stand with vaccines. So check our website and register for that. Thank you.
Thank you very much, Janet. It's wonderful. Now we move into the phase of thank yous. As mentioned, we move into the phase of thank yous, and we'll spotlight Krish, Anastasia, myself, and the principal to have final wind-up remarks and thank yous.
Thanks so much, Dr. Angel. And once again, thanks so much for our wonderful audience for joining us today. I know it's at the end of everyone's afternoons, and I'm grateful that people were able to spare about an hour and a half to join us. Also, thank you so much, Dr. Rassant, for your wonderful comments, and we'll surely join your Gairdner programming afterwards as well. As a student currently doing clinical rotations during COVID, you can imagine medical training has been nothing short of ordinary during the pandemic. And I'm grateful that the lessons that we've had here around psychological PPE, the future of graduate training, which also might apply to medical training, as well as our main lecture on the cardiovascular impacts of COVID are surely going to be important lessons to draw moving forward into any of the careers that we as future medical students and graduate students will take forward. I'll leave it to you, Anastasia.
Yes, thank you very much, everyone, for your talks that sort of broadened our perspective on the whole situation. I, for one, I'm excited. I think that as soon as we identify these problems, these are opportunities for us to come up with new solutions. So I'm looking forward to seeing what comes up in the years to come in terms of addressing these problems that maybe we have already had in our society for a long time, and now COVID has brought the spotlight to that. So looking forward to a brighter future.
Thank you very much. Well, it's my opportunity now to invite Principal DeRosier to give thanks. Is she available for that?
I believe her connection may have cut short, so we'll just have to wrap up without her.
All right, well then let me take this opportunity to give thanks to many people for their contributions, particularly Krish and Anastasia for co-chairing and assisting in developing the program. Thank you so much for your efforts, brilliantly done. Very pleased with that. Now, Alicia, our technical support for the COVID event discussion today, thank you. Now, special thanks and recognitions to our panelists, Alan Kaplan, Reinhart Reithmeier, wonderful colleagues at Massey, senior fellows dedicated to graduate education and the junior fellowship. Wonderful to have you here and share your expertise. Finally, Dr. Sonia Anand, how many times can I thank you for your durability, persistence, support for the Rossant Lectureship, and participating twice within an academic year in the Massey Grand Rounds Symposium activity. As mentioned before, we owe you some social indebtedness, and we hope that when things lighten up and we do things in person, Dr. Anand, we can have you back for fun. This now completes your responsibilities as the 2020 Rossant lecturer, and I hope that we can continue to call on you for years to come and continue your affiliation with Massey Grand Rounds, even from Hamilton. Now, it is an opportunity for me to also remind everybody that the 2021 cycle for the Janet Rossant lecture is presently actively being developed, and we hope to announce the winner for the next cycle shortly, and anticipate the Massey Grand Rounds Symposium perhaps sometimes in November with the third annual Janet Rossant lectureship. And with that, I'd like to close the program and thank you all for wonderful participation, wonderful content, and we'll see you all again on YouTube sooner rather than later. Thank you so much.
Thanks so much.
Thank you.